The Health Systems Trust, in collaboration with the Health, Economics and AIDS Research Division, are proud to present the 24th edition of the South African Health Review.
The 2021 edition of the South African Health Review provides a platform to reflect on how best to leverage the experiences, lessons, and rapid innovations arising out of our response to COVID-19.
This special edition, entitled COVID-19, What Have We Learned?, documents the South African health sector's response to COVID-19, provides examples of innovations, best practices, and collaboration, and assesses the impact of COVID-19 on vulnerable populations.
Valuable lessons that have been documented, data that has been collected, analysed, reviewed, and hopefully it's these lessons that will be used in the conversations, in the planning that will be undertaken to ensure that we effectively manage COVID-19 from here on in, to ensure that it becomes endemic.
The suite of chapters is presented in 5 sections. Evidence-informed decision-making is the fundamental ethic of medical scientists and practitioners. Chapters in the first section outline evidence to policy approaches utilized for developing national strategies to protect both lives and livelihoods. Blecher and colleagues review the economic and epidemiological modeling that was used to inform priority setting for public finance on health and income protection.
But then it comes to focus on the economy, so both on the effects on GDP, but the effects on various fiscal indicators and debt, and ultimately the effects on spending by government departments such as health. So whereas around 20 billion additional was allocated to the health sector for COVID, around 120 billion needed to be allocated also through insurance mechanisms, public insurance mechanisms for some of the livelihood implications of COVID. But all of this ended up coming through and putting tremendous pressure on the budget and subsequent reductions in health budgets over subsequent years.
In chapters 6 to 14, authors share the experiences of first responders and the general population in relation to the pandemic. Insights on public and private healthcare service provision are provided by nurses, psychiatrists, and occupational therapists regarding their interactions with the public. Authors in this section also explore the COVID-19 experiences of vulnerable populations, including people living with disabilities and children. In Chapter 6, Kelly et al. Share poignant insights on how public healthcare facility nurses in the Eastern Cape navigated service delivery dilemmas during the first wave of the pandemic.
We had 3 key findings that emerged from our study. The first is that the pandemic clearly placed an additional burden on already resource-constrained healthcare facilities and healthcare workers, and this was compounded by things like delayed restocking of COVID equipment and COVID-related medicines. The second is that nurses clearly experienced internal conflicts and daily dilemmas associated with the pandemic, and this impacted not only their own health and well-being, but also their ability to effectively deliver services. The third is that despite these challenges, what was really inspiring to see is that they still had a very clear willingness and drive to meet the needs of their patients. And they did things like forming a response committee to address COVID-related challenges, drawing on the services of community-based caregivers to deliver medication.
In Chapter 7, Mamecha et al. Draw from data on hospital admissions and mortality outcomes to identify COVID-19 risk groups among members of the government employee medical scheme across the 3 COVID-19 waves. These groups being personnel in the departments of health, police services, and correctional services.
We found that the correctional services, the police, and the health sector had high risk of COVID-19 infection, and in wave 3 it was interesting because the health sector had reduced infection rates and mortality, and this can be due to the immunization that they had received. We also found that, interestingly, that income was associated with high infections and admissions to hospital, but not death. And this suggests that income is still a determinant of access to health services in South Africa, despite the equal access to healthcare funding, which in this case is COVID-19 is a prescribing benefit.
Chapter 8 by Solanke et al. Shares experiences on formulating a public-private partnership service-level agreement to address shortfalls in COVID-19 critical care capacity in the public sector.
The problem when we faced the early waves of COVID was that all the overseas information showed hospital beds getting really full and critical care running out. And so the question was, if it hit us really hard, how many hospital beds did we have available, and in particular, ICU and high care beds? With that in mind, it was realized that 75% of high care beds actually resided in the private sector. And perhaps one of the few ways you can provide enough beds is then to have a partnership with the private and public sectors working together. The Western Cape team put together a service level agreement, but the process of achieving that agreement was way more complex than anybody imagined. And in the end, the actual number of patients that had to be transferred from the public to the private sector was very, very small and of experimental value only. But what we did learn was about the complexity of the two sectors, the difficulty of getting them to agree on common forms of care and of tariffs and of indemnity, and who would administer the complicated bureaucracy of payment and reimbursement.
Strengthening the health system to maintain essential health services during the COVID-19 pandemic is critical. And in Chapter 10, Pattinson et al. Examine the impact of the first and second COVID-19 waves on maternal perinatal mortality and the use of maternal and reproductive health services.
There was a significant and a 40% increase in maternal deaths, a 10% increase in stillbirth rates, and a non-significant but 3.6% increase in neonatal mortality rates. Although antenatal services were maintained, there was a marked movement of women from urban to rural areas. There was a significant decline in the use of reproductive health services, with a 5% decrease in contraceptive prescriptions and a 17% decrease in women attending termination of pregnancy clinics. Overall, the COVID pandemic has had a significant impact on pregnant women and their health, and health systems should be strengthened to maintain services during a pandemic.
Sections 3 and 4 examine sectoral collaborations and the COVID-19 response in relation to the needs of vulnerable groups. In Chapter 12, Ned et al. Focus on people living with disabilities, bolstering the argument that health services are not disability inclusive and that this population experiences significant states of vulnerability.
So, for instance, for people who have routine checks or ongoing therapy, those were cancelled because of the lockdown regulations. So we see a case where then within the health system, the disability and rehabilitation related services were actually not prioritized as essential services, and that put people behind. We also saw issues related to access to information that is accessible and communication that is accessible to all people with disabilities. And those were some of the issues that created further barriers and challenges when it comes to people with disabilities. And some of these issues actually led to lots of feelings related to anxiety and stress, which then are likely to increase mental health problems that we have in the country.
In Chapter 13, authors vividly describe psychiatric workers' mental health experiences during the pandemic across southern Gauteng and shares key policy recommendations for improving public mental health.
So we did a study looking at a sample of public mental care workers in southern Gauteng in the hospital sectors. We looked at psychiatrists, registrars, and nurses mostly. We found that they were highly stressed during both lockdown level 5 to 4 and 3 to 1. And in 3 to 1, they had raised levels of depression, anxiety, PTSD. We found that it was mainly due to fear of infecting themselves and others. It was because of increased work demands that they had burnout. And we also found that it was a manifestation of chronic underfunding and overburdened mental health care system.
In this section, chapters 15 to 20 illustrate intersectoral collaborations in response to COVID-19 and identify lessons for improving emergency preparedness and health systems strengthening. Chapter 17 documents intersectoral collaborations across government sectors before and during the COVID-19 pandemic in the Western Cape, together with the lessons and opportunities that these experiences offer for maintaining health and well-being.
We did quite a bit of groundwork prior to COVID in whole of society approaches, but during COVID we learned three key things. One was that the health department was invited to give technical support to other sectors, which built trust. The second one is we had a very formalized disaster management approach where all sectors came together in a structural way. But the third one is we built on our previous experiences of a more collaborative approach to safety as part of the recovery in the Western Cape. So our key recommendations are that learning from all of these, going forward, having a combination of a structural or top-down intent to work together across sectors, together with a more collaborative and trust-building and relationship-building exercise from the bottom, is probably the best formula to make a big success of intersectoral collaboration, addressing social determinants and well-being.
Community health workers have continued to play a crucial role during COVID-19, including case studies, identification, and referrals for testing and to health facilities. Matigizela and colleagues in Chapter 18 focus on the leveraging of ward-based primary health care outreach teams for community-based screening and testing.
Community health care workers partnered up with the clinicians, which were nurses, some of whom were OTLs and some of whom were deployed from facilities. They went door-to-door screening and testing all those that were identified to have the symptoms as per the guidelines. This was successful in a sense that we were able to identify areas of transmission in our communities, especially where we had high transmission, because we saw the increase in terms of the positivity rate in the areas where community health care workers were screening and testing, and it assisted a lot in terms of targeting the interventions, the COVID-19 interventions in our communities.
Leaving no one behind is the foundational tenet for universal health coverage. Chapters 21 to 24 explore lessons learned from the COVID-19 response for vulnerable populations and highlighted the structural challenges and restrictions faced by migrants, homeless people, and those with opioid dependence in accessing COVID-19 related healthcare. The last section covered structural and social barriers against access to and the availability of COVID-19 vaccines. This content elucidated inequities in the global vaccination initiatives.
Colleagues, the 24th edition of the South African Health Review asks the basic question. The main highlights from the review include the importance of the need for strong data systems, particularly economic and epidemiological data in order to inform the response. The review also points to the importance of private and public health partnerships in managing the COVID-19 response. Another key highlight of the review is the importance of understanding the population needs of South Africans in accessing health services during the COVID-19 pandemic.
In a fitting way to close the edition, Chapter 29 by Ndlovu et al. Focuses on a repository of data specifically on health status, health service, and socio-demographic indicators to demonstrate how COVID-19 has affected the provision of healthcare in South Africa.
COVID-19 has had a negative impact on health systems across the country and has resulted in many collateral impacts on health service delivery and outcome. Longer-term impacts are expected due to disruptions in health service delivery for both non-communicable and communicable diseases. As South Africa transitions to managing COVID-19 as an endemic disease, a key task will be to retain what is most useful in health information systems and other innovations.
This edition highlights the abiding importance of data and information for making rational health decisions, the strength of multi-sectoral partnerships, and the need for strong legislative and ethical mechanisms to underpin improvement of healthcare services and to facilitate health research.
I'd like to thank and congratulate all the authors for this timely publication. You've looked at different aspects of the pandemic, of the disease, and looked at health system strengthening. You've looked at technology, you've looked at the impact on children and how healthcare is provided. And from these insights, we'll be able to make recommendations and changes to improve the health systems and also to empower the healthcare community as well.
I believe it's a very useful resource for the country. We are privileged to have been able to contribute in this way, and I do believe that the lessons learned will be useful going forward. And as the Health Systems Trust, we're very grateful to all who have contributed to its production and hopefully its long-lasting impact going forward.